I'm Paul Cressey. If you were here yesterday, Maya hinted at my talk by showing a few slides. So my talk is on Carboplatin and SN-38 thermosensitive liposomes that can be triggered by focused ultrasound to enable the treatment of triple-negative breast cancer. So a little bit of background. This will go to the next slide. There we go. Why do we want to use liposomes for cancer therapy? Well, small molecule chemotherapeutics, they work, but they're not great. You have drug resistance from the platinums. You have poor bioavailability of one of the drugs that is mentioned in the title, SN-38 here, is basically insoluble and is only given as its prodrug form, irinotecan. They have high systemic toxicities and poor pharmacokinetic profiles. Basically, yeah, they're not great. But if you put them in nanoparticles, you can limit some of these off-target interactions that limits the side effects, and you can tune the blood half-lives of how long do you actually want them around. With the small molecule, you have no control over this. There's been some success in the clinic with a few of them outlined down here, but the one I'm interested in is Thermodox. Thermodox is a thermosensitive liposome formulation that was in trials for a liver cell line cancer. What is a thermosensitive liposome? Okay, it's a bit of a weird name. So a thermosensitive liposome has a phase transition temperature in the mild hypothermia range. So it's between 40 and 45 degrees. Basically, if you're below this transition temperature, the liposome is in its gel phase. And this membrane here is solid. So whatever you've got inside can't really get out. But once you heat it up, it goes through a phase transition temperature and and goes into its liquid crystal phase. In this case, this membrane is now permeable, so whatever you had inside can leak out. Here are some of the lipids that are normally used for these type of formulations. You have some PEG lipid in there for in vivo stability, DPPC, DSPC, but the important one is here. This is MSPC, it's a lysolipid. By putting this in, you dramatically increase the rate of this drug release. It goes from high minutes to seconds, depending on your drugs. Okay, so it's all good. However, there is one bad thing of thermosensitive liposomes. These thermosensitive properties that give them this rapid drug release also means that at 37 degrees, they still leak drugs. Thermodox especially leaks a lot of doxorubicin very quickly in serum/blood. So we'll get back to that later. But we've got these thermosensitive liposomes, how we're going to heat them. Maya spoke a lot about this yesterday, but I'm just going to go over the quick basics. We can use something called focused ultrasound. It's a technique for non-invasively depositing energy inside tissues. It has a tissue depth of about 10 centimeters, and you can either go hypothermia with it, or if you crank up the power, you can ablate, you can cook things with it. It can also be coupled with MR imaging to track your particles if you put a MR contrast agent on them, but also you can use MR thermography to get a feedback loop of the temperature you are depositing into your tumor. A thing I like to show is this. This is a simple diagram of the peak intensity of your focused ultrasound focal spot. As you can see, it drops exponentially with distance. So only the focal spot heats, and the focal spot for real life, so you can actually imagine it, is about the size of a grain of rice. So it's not very big, which is pretty good. So that's some background, but what did I actually want to do? So this is my proposed particle over here on the left. It has a MRI contrast lipid, which is down here. So it's a gadolinium DOTA-based contrast. It has SN-38 that I want to incorporate into this membrane, which the membrane of the thermosensitive liposomes is very important. I want to put carboplatin in the core, and then I also incorporated a near-infrared dye for making in vivo biodistribution tracking easier, and also some PEG in there for a bit of in vivo stability. So the idea is I heat this for 10 minutes at 42 degrees, and the carboplatin rapidly leaks out, or is released. Then, while it's in the tumor, the liposomes will slowly degrade, releasing the very potent SN-38. So you kind of two-hit them. You hit them with a large burst of platinum, which sensitizes all the cells, and then you hit them with SN-38, which will hopefully finish them off. SN-38, though, has another issue with it, other than it not being soluble at all. It's also incredibly pH sensitive because of this lactone here. This is the pH titration I did. And you can see that to be in the lactone form, which is the active form, you need to be in the pH 5 to 6 range. You start going above, you start this ring opening reaction and completely kill any activity of your SN-38. So all my formulations are done at pH 5 for this entire reason. There is a cool thing that this ring open does, but I don't really have time to talk about it. So on to loading. So I get my liposome formulation, which is up here, and I start doping it with SN-38 and seeing how much can I cram into that membrane before I start losing that tight thermosensitivity transition. And it's about 5% drug to lipid ratio you can get in before it starts actually having an effect, which for something as potent as SN-38 is a lot. And it encapsulates very well. You get an encapsulation efficiency after purification via dialysis of about 75%. Sizes is pretty good, 140 nanometers. It's quite nice. So then let's go on to, I want to put a second drug in here. What effect does that have? So first I had to see, is carboplatin still soluble at pH 5? Because there's nothing in the literature, because everyone does it at physiological pH, pH 7.4, pH 7 for some people, but is it still soluble at pH 5? Luckily for me, yes it is. It was a relief, that one. So we just do a hydration loading with this. So I just hydrate my lipid film with 15 mg per mil carboplatin and then dialyze off the excess. It works quite well. I get an encapsulation efficiency of about 5.6%. It's okay for that method. But if you think of this drug, it's a 30 mg per mil liposome. It's got 2 mg per mil of drugs in it. It's got a lot of drugs in this liposome. But I said I want the platinum to release in the SN-38 now. So I had to check that. Is this still a thermosensitive liposome? Well, if we heat them for 10 minutes at varying temperatures, we can see the SN-38 does not leave, which is what I wanted. But the carboplatin, when I go to 40 degrees or above, when I hit the hypothermia range, I get a rapid release of platinum with almost complete release at 42 degrees, which is great. But I mentioned earlier that thermosensitive liposomes aren't stable in serum conditions. So are mine. So I tracked the contrast lipid as a marker for the actual liposome itself of how stable is my liposome. Does it just fall apart in serum? It does not, which is great. What about SN-38? This is just some FBS. So I didn't expect my liposomes to fall apart like they would in a tumor. And again, my SN-38 doesn't leave. My carboplatin leaks a little bit, but I don't actually see any significant leakage till about 4 hours, which if you compare this to, say, a Thermodox-like formulation, it leaks 30% in about 30 minutes. So compared to a Thermodox-like formulation, this thing is incredibly stable, but still releases the drug on heating. So that was great. When I saw this, I was very happy. So I was like, well, we've got all this release studies, but does it actually kill? You know, I could make this formulation, but it doesn't kill cells. What's the point? So I did some very brief MTT assay on my liposomes with no drug in them, which is non-toxic, which is great. And then with my drugs. You can see that with heating, so preheating the formulation for 45 to 45 degrees for 10 minutes before I treat the cells, I get a slight increase in toxicity, which is due to the carboplatin release. And I did monitor this via cell uptake, and I do see an increase in platinum uptake, which is great. But this shows me that the SN-38 does actually still leave the liposomes because it kills. So I was happy. How do they behave in an animal, though? So I got some mice. I injected them with my formulation. I did my formulation dosing off the SN-38 because I've developed a very quick and easy fluorescence assay to determine the concentration. The almost one-to-one ratio in the drug concentrations was conserved when I measured them via ICP-MS versus my fluorescence. So I thought dosing off my SN-38 was easier, and I didn't have to wait a week for my ICP-MS results to come back. So you can see here that actually they're not as stable in blood as they are in serum-like conditions. Surprising nobody. But you can see the gadolinium here that I'm using as, again, a surrogate of my liposomes has a relatively straightforward blood clearance. The platinum, or carboplatin, is conserved for the first about half an hour and then starts to deviate. So I attributed this to the carboplatin remains encapsulated for about half an hour and then it starts leaking out, which is better than, as I say, a Thermodox-like formulation where it leaks almost instantaneously. And we've seen this with a doxorubicin loaded of this formulation, that the dox starts leaking out straight away. So that was good. But where does it go? If it's like in the serum, in the blood, whatever, where does it actually end up? So if we just inject, it goes to the liver. Surprising nobody at all. You get a very minor amount in the tumor. However, if we do the focused ultrasound on the tumor, following this protocol up here, where we inject, about 10 minutes after injection, we heat the tumor site from 42 degrees for 10 minutes. We see a dramatic increase in tumor uptake for this thing. And obviously, if it's going into the tumor, less gets into the liver, so we see a decrease in liver uptake. When I saw this, it was wow. Yeah, I was like, I've got to quantify this. I have to know how much more is getting into that tumor. And that's exactly what I did. So the no fuss, I get about 2.5% of my injected dose into the tumor. When I do focused ultrasound, my hypothermia, that jumps up to 7.5 to 8%. It is 2.5-fold higher increase in tumor uptake. It is massive, this increase. It's mostly due, I think, and the literature is kind of catching up and agreeing with this, of when you heat the tumor with the ultrasound, you disrupt the interstitial pressure. So the tumor is no longer pushing everything out, so your stuff can get in easier. So you get a marked increase. But does it work? So I get this increase in tumor uptake, but what does that attribute to? So we'll go to the tumor volume that Maya hinted at yesterday, and I was like, oh dear, I thought she was going to tell my entire story, but she didn't, thank God. If we do no treatment or we treat with free drugs, in this case, I had to treat with irinotecan. As I said before, I can't treat with SN-38 because it's not soluble. And my liposomes on their own, they follow very similar growth curves. It slows it a little bit, but not a lot. However, when I do the focused ultrasound treatment, I get complete halt of tumor growth for 9 days, and then it slowly starts to recover. This formulation, including the ultrasound, is tolerated incredibly well, with pretty much no change or no significant change in body weight at all for any of this. And this is amazing because the doxorubicin formulation, this body weight goes through the floor. They do not like dogs, but this formulation, okay, they quite like it. But what does it actually mean? Well, it means this. You go from 14 days survival to 35 with one dose, 10 minutes of heat. That is it. This is not multiple doses. This is not multiple heating. This is one of both. And you get a 2.5, ironically, yeah, a 2.5-fold increase in survivability as well. It likes 2.5 did this particle, but it is what it is. We get a moderate increase in survivability with the free drugs, which is to be expected, but not as much as this. So quick conclusion, the imageable thermosensitive liposomes can be loaded with platinum and SN-38 and retain their thermosensitive properties. They are small and display a high drug retention in serum and in blood circulation. They take half an hour before they start leaking. 10 minutes of focused ultrasound and one dose causes dramatic improvement in its anti-tumor activity. And as I was kind of hinting at as we were going along, this technology can be readily modified to incorporate various drug combinations, which I think should be done, as long as you follow a few generic rules that I kind of figured out as I was going along of, if you want to load into the core, it has to be very water soluble because you have to hydrate it. Or you can do salt gradients, but I'm not sure how that would affect the membrane loading, but you probably can do it. And if you want to load into the membrane, your thing has to be very potent and very hydrophobic because you can't get a lot in there without starting to kill the thermosensitivity. But if your drugs obey these very loose guidelines, we'll call them, rather than rules, then this technology will work. So quick acknowledgements. I'd like to thank the funders and my supervisor for this PhD work, which was Maya Thanu, and then the postdocs in the lab at the time was Mike Wright and Miguel, and Morale was a fellow PhD student who was working on a very similar project. We did the animal work together, but she's passed her defense, so she's a doctor now too. And if there's any questions.
Thank you, Paul. Great talk. Really interesting. I think we're tight on time, so I'll just ask one of the questions that's come up. I had a few myself, but I think we'll just cover this one. So it's an interesting question from Ashwin. So he was just saying, but I think my reading is, the question is, does the carboplatin combined with the ultrasound when injected at the tumor site have any effect? So are the liposomes really key to this, or could you just administer and then kind of use ultrasound to improve the effect of drugs alone at the site?
You could definitely just use ultrasound to increase the uptake a little bit. But the problem being is the half-life of, say, carboplatin on its own, its serum half-life, is 9 minutes. And to set up this ultrasound experiment, you basically have to do a carboplatin infusion while you're doing this, and that's not particularly practical. Okay. Whereas if you've got it in the particle, it just makes everything a bit easier, and you're making sure that you're getting both drugs there at the same time. Yeah. Because they're both in the particle, yeah? If you delivered, say, platinum on its own and then tried to deliver irinotecan on its own, they have different half-lives in plasma, because irinotecan has to go via a liver pass first before it's active, so they're never going to see each other. Yeah. This is the issue. Whereas if you put them both in the same particle, they're there at the same time.